Dr. McKenzie.
Thank you. Thank you very much. And that's the short version. I'll tell you about the fishing boat in Alaska some other time. So thank you to those of you who are here coming from the last talk. That's always encouraging. Thank you to everyone for showing up at the very end. Don't know, this is obviously the third in a series of talks. The first one happened a couple days ago, and the second one happened just about a half an hour ago. They're all self-sufficient, so if you weren't at the others, it'll still make sense, but I'm going to refer back to some of the others. So just my disclosure, as mentioned, I work for Loyal, which is a biotechnology company. We're working on drugs to try to help dogs live longer, and I'm also still 2 days a week in the same practice I've been at for over 20 years. Key things we're going to talk about first is metabolic aging. So I've been talking a lot, especially in the other sessions, about the biology of aging or the mechanisms of aging, and I want to get a little more specific about examples of that so that it feels real and we know that we're actually talking about something meaningful. Then I'm going to talk about clinical lab tests, all the CDC chemistry things that you run already, some of the things that maybe you don't run but might be coming in the near future as commercial assays, and that give us some insight into how individual patients are aging and maybe what we can do for them. And then answer that question. So what? What do we do for them, right? What is available to try to interact with this biology in a productive way? So this is the canine geriatric syndrome. For those of you who are at the other talks, it'll be familiar. It's just a system for organizing the stuff we know about how aging works in dogs in a productive way for both researchers and clinicians. I've talked about frailty, which is a measure of the impact of aging on individual dogs. It's a test or a number that you get that tells you how significantly aging has impaired the health, well-being, and function of a given dog. I've talked about caregiver burden, quality of life, which is sort of a life-limiting factor for our patients. I went through in the last section some of the specifics about disease and the physical, functional, behavioral changes. This one is all going to be about metabolic changes. And when I say metabolic, I used to start this presentation with a picture of the citric acid or the Krebs cycle and tell everyone I was going to spend an hour talking about that. And then I would just say, oh no, that was just a joke. But I would see real fear in people's faces when I did that. So I don't want you to get scared. Metabolic is not going to be really dense biochemistry. It's actually quite intuitive. So metabolism, metabolic dysfunction is just a way of saying that metabolism changes in ways that are counterproductive and that increase the risk of disability, disease, and death, what I call the 3 Ds of aging, okay? And it's a spectrum. So young, healthy folks and dogs and cats have a metabolism that is very efficient and very flexible, and then aging and other factors like lifestyle change that metabolic function in ways that are less and less helpful and functional until you reach the extremes of some diagnosable metabolic disease. In humans, it's most often what we call metabolic syndrome, which has a very specific definition. There's some debate about the extent to which metabolic syndrome exists in dogs, so we'll talk about that. There's also something known as ORMD, or obesity-related metabolic disease, which is very similar. So dogs and humans age in remarkably similar ways, but there are some small differences, and I think those can be interesting and useful to look at. So again, in youth, metabolism is flexible and efficient. I used to eat anything I wanted, and I stayed skinny, and I felt good, and life was great. And then as we get older, that changes. And that changes in measurable, specific ways. And I'm going to talk about these 3 categories of changes here. Changes in insulin resistance and the levels of insulin. Changes in the adipose tissue, how it works, where it is, what it does. And changes in blood lipids. All of these changes are then general drivers of age-related disease. And the power of studying aging and dealing with the mechanisms of aging is that it is a driver of a bunch of different diseases that we think about as having separate pathophysiologies, right? Cancer is different from arthritis, it's different from cognitive dysfunction. And they are different, but they all have roots in what I call the modifiable risk factor that is aging, right? It is just a way of increasing the risk of these diseases, and there's something we can do about it. So just as a refresher on insulin, right, the way I like to say it is insulin is the key that opens the lock in the door that lets glucose into the cell so it can be used as an energy source. And what happens with aging is that lock gets kind of rusty and the key doesn't quite fit. So peripheral tissues, particularly skeletal muscle, the liver, become resistant to the effects of insulin. And then the body goes, well, shucks, the insulin's not doing the thing it's supposed to do. I need to make more insulin. So then insulin levels tend to go up with age. But insulin does other things besides letting glucose into the cell. It's a trophic hormone, right? It has growth-promoting effects, which, as you can imagine, increases the risk of neoplasia. In humans, it's well known to be a risk factor for cognitive dysfunction or dementia. So too much insulin accumulating with age because of this peripheral resistance is a driver of a variety of different kinds of age-related disease. Adipose tissue, we don't think about it very much other than as a storage organ for calories, but it's actually a very metabolically important organ. And it changes with aging in a couple of key ways. One is that in general, the total amount of adipose tissue goes up in humans and in dogs and in most other species with aging, right? And some of that is exacerbated by chronic overnutrition, which is a problem for us and for our pets, but some of it is just a natural feature of metabolic change with age. It also changes where the adipose is. So adipose tissue in different parts of the body work in different ways. Subcutaneous adipose is a relatively benign storage organ for calories, and it doesn't tend to have a lot of negative metabolic effects. But visceral adipose in and around the abdominal organs tends to behave very differently and have a lot of more significant negative health effects. And as aging proceeds, both humans and dogs tend to see a shift in where adipose is stored from the subcutaneous to the visceral compartment. And that has effects on metabolism and health. And then the function of adipose tissue changes, partly as a consequence of this distribution change, but also as part of the aging process. So adipose tissue becomes less efficient at metabolizing and utilizing fatty acids, and so fats begin to circulate in the blood in ways that they didn't before. That then leads to the ectopic distribution of fat into places it doesn't belong. So you can imagine fat in your skeletal muscle, your cardiac muscle, your pancreas is going to impede the normal healthy functioning of those tissues. And then there are changes in the signaling of fat cells. Adipocytes will start putting out more pro-inflammatory mediators and less metabolically protective mediators. A good example of that is something called adiponectin, which is, generally speaking, a metabolically protective hormone that improves insulin sensitivity, improves the efficiency of free fatty acid metabolism in the liver, the skeletal muscle, that generally is protective against the negative metabolic effects of aging, and that tends to go down with time. Aging individuals produce less of this. And then finally, blood lipids. And this sometimes comes as a surprise to veterinarians because we just don't talk a lot about lipids in our canine patients, right? If they're hypothyroid or have Cushing's or some sort of familial hyperlipidemia, we might talk about it. But we kind of see the cholesterol creep up in dogs as they get older, and we don't think much about it because they don't get atherosclerosis, they don't have MIs, they don't have strokes. But it turns out that they do have actually surprisingly similar changes in their blood lipids to humans, and that these are risk factors for health problems, for the 3Ds, disability, disease, and death. Just different manifestations than we tend to see in other species. So this is a little chart just comparing these sort of aspects of metabolic health in humans and dogs to show you how much similarity there is, right? The main differences are that as humans age and with peripheral insulin resistance, they do tend to develop high glucose levels. Dogs don't seem to do that. If anything, their glucose tends to go down as they get older. We don't have a really absolute explanation for this. I think some of it may be that the pancreas is less fragile and continues to produce insulin, and the beta cells don't all die off from glucose toxicity the way they do in cats and people, which is probably why we don't see type 2 diabetes in dogs nearly as often as we do in humans or cats. But in any case, that's one difference. The other is that they have a different set of lipoproteins, and so we don't tend to think about, LDL going up and HDL going down in quite the same way that we do in humans. But most of the other changes are quite the same. Peripheral insulin resistance, hyperinsulinemia, shifts in the amount, distribution, and function of fat, and changes in lots of other blood lipids like triglycerides, total cholesterol. So why does this happen? What causes metabolic dysfunction? Well, there are three main things that lead to metabolic dysfunction. The first is you can do it on purpose. High-fat diets are a way of inducing metabolic disease. This is frequently done in laboratory studies, initially to model obesity, but now it's actually being used as a model of metabolic aging, because it turns out you see similar changes in a shorter period of time in dogs fed a high-fat diet as you see in lean dogs as they age normally. Obviously, chronic calorie excess is a major cause of metabolic dysfunction. A high proportion of our dogs are overweight or obese, and that leads to many of the same changes. The thing that I just want to emphasize, though, is that obesity is not the only reason that dogs develop these metabolic dysfunction symptoms, right? These happen in lean dogs with age, as well as in obese dogs. They happen earlier and to a greater extent in dogs who are overweight or obese. So aging is one of the main drivers of metabolic dysfunction. And why do we care? What does it do that's a problem? Well, as I mentioned, it's a driver of aging-related disease and a lot of different kinds of diseases. So how does that work? Well, here's an example that I think illustrates the issue a little bit. This is from what's called the purina caloric restriction study. How many people are familiar with that? Good, more people every time I do this. This is great. So for those of you who are not, fairly simple design. They took Labrador Retriever puppies and they randomized 2 puppies from each litter, one to a control diet and one to a restricted calorie diet. The control diet was initially ad lib feeding. You can imagine how that's going to make Labrador retrievers look pretty quickly, and it wasn't meant to be an obesity study, so they changed the protocol to feed that to a healthy body condition. They got about a 6 out of 9, so they were a little chubby, but not bad. So basically a normal body condition or close. The caloric restriction puppy then got 25% fewer calories than its littermate ate the day before. So it was a pretty significant calorie restriction study. To give you a sense of the strength of this, in these kinds of studies done in lab animals, usually the restriction is anywhere from 25 to 50% below maintenance calorie levels. In humans, they tried to do a caloric restriction study. They aimed for 12%. They got people to 9. That was all we could put up with, right? So it's hard to do. It's a pretty extreme calorie restriction. It's not a normal kind of diet that you could do in a clinic. And in doing this, they saw that the calorie restriction dogs lived almost 2 years longer on average than the dogs who were on a normal, healthy calorie level. They also saw a delay in age-related disease. These dogs mostly got all the things you expect older Labrador retrievers to get, right? They got arthritis, they got cancer, but they got them 1, 2, 3 years later than the dogs who were on the healthy diet. And what's interesting about this, again, is not that this is a clinically useful strategy, because I'm not going to tell my clients to starve their dogs to be healthier, right? But they were able to identify changes in insulin metabolism and insulin levels as a significant predictor of outcomes. So those dogs in the control group had a much higher insulin resistance, and that was predictive of their outcomes. So it's just a good illustration of the importance of this aspect of metabolic dysfunction in driving age-related disease, and the potential for targeting it in order to extend lifespan and health span, even if we target it in ways other than through calorie restriction. So we've been doing some research at Loyal. This is from a study called the HealthSpan study. This was about 450 client-owned dogs. It was an observational study. So we came in, we collected a lot of lab samples. We did some instruments to measure the impact of aging. One of those was a frailty instrument. I talked a little bit about frailty. The other was a quality of life tool, using to ask the owner how quality of life was in their dog. And we looked at some of these elements of metabolic dysfunction to see how they were associated with age and with health. So this was just showing that, in fact, insulin levels do tend to go up over time in dogs, so we're confirming what we already suspected. And then for the first time that I'm aware of, we were able to show that this increasing insulin level with age was associated with a clinically meaningful outcome. In this case, an increasing risk of frailty. So the dogs who were more frail were also more likely to have higher insulin levels. This suggests that metabolic dysfunction is driving the negative clinical consequences of aging in these dogs. Right? We saw the same thing with health-related quality of life. Quality of life was lower in dogs who had higher insulin levels, suggesting that they were overall less healthy. And again, this is not necessarily any particular disease. This is a general function of aging. So then we started looking at some of these other things. I've already mentioned that glucose changes in humans. Glucose tends to go up with age, and that's associated with negative outcomes. In our population, glucose tended to go down with age. And in the literature reviews I've done, generally that's pretty consistent. Some studies are equivocal, but most of them tend to show that glucose decreases with age in dogs. And this may be a function of that hyperinsulinemia, that compensation for insulin resistance, just being more effective in dogs for different reasons than in humans. This too is associated with frailty, though, which is interesting, right? High glucose is a bad thing in humans because it's associated with metabolic dysfunction, but the same kind of metabolic dysfunction is a bad thing in dogs, even though it's associated with a lower glucose level. So different ways of responding to the same problem, but leading to the same negative outcomes. Now, this is a graph or chart that I want to spend a little time on because I'm going to show it a bunch of times, and sometimes it's a little confusing what it is. This is from a paper done through an experiment with Purina, where they took a bunch of commonly measured clinical lab values, and they created a couple of things. One, they associated them with particular health outcomes like mortality, which is what this is showing. They also created a tool for measuring biological age, right? How much has aging impacted the dog, and how is that different from their chronological age? So the way this works is they've looked at cats, humans, and dogs with different pre-existing data sets where they already know the outcome for the dogs, and applied this tool. They have looked at outcomes that increase the risk of death as that particular value goes up. So in this case, this is white blood cell count, and higher white blood cell count is associated with a higher mortality hazard in these patients. That's why it's red. If it's blue, that means a higher value is associated with a lower mortality hazard. So in this case, if your hematocrit is higher, that's a lower risk. And then the stars are just degree of statistical significance. So you can see, in this case, when you look at glucose, that there is a little bit of a negative association. Glucose, when it's higher, is associated with mortality in humans, but that association was not seen in dogs. Okay, so that just echoes what we found in our studies as well. Now, we all know that too much adipose is bad, right? And that adipose accumulation is part of the aging process. And this is from a paper that specifically looked at a wide range of different dogs. That graph there is for Yorkshire Terriers, but the chart shows a lot of different dogs of different breeds and sizes. And in all of them, dogs who were overweight or obese had a shorter life expectancy than dogs who were healthy body weight. So we know that too much adipose is bad. And it's associated with a variety of the negative outcomes associated with aging. So quality of life is lower, risk of a variety of different diseases is higher. So not only osteoarthritis, which we expect, diabetes, which maybe you would expect even though it's less common in dogs, but things like respiratory disease or dermatological conditions, right? Too much fat creates a pro-inflammatory environment, which is a risk factor for lots of things other than the obvious diseases that we think of. And just as in humans, there is a shift in the deposition of fat from the subcutaneous to the visceral space as dogs get older. So they tend to get bigger bellies, and more of their fat goes into their visceral space. Now, we have a little less data on the health implications of this than we do in humans. This was a study that looked specifically at the issue of insulin sensitivity, and they found that the more fat you had in your abdomen as a dog compared to your subcutaneous space, the higher insulin resistance and the higher insulin levels that you had. So fits, right, that this is a negative metabolic feature that reduces insulin sensitivity. Visceral fat may in fact be a main driver of insulin resistance in peripheral tissues. And what they found is that you could actually remove the amount of visceral fat by taking the omentum out. So you take some fat out of the abdominal cavity, and that improved insulin sensitivity, which shows you how important this is. Now, again, not a clinically practical thing, right? Omentectomy is not the answer to, insulin resistance in aging dogs, but a good proof of the concept and why this is important. They also found that for some diseases in this study, abdominal obesity was a better predictor of heart disease than overall body condition. Right? So this is another reminder that particular diseases are associated with this increase in visceral adipose. So we looked at some of the function of adipose in our study. We looked at adiponectin, again, a metabolically protective hormone that's generally associated with better health and longer life. We found that, yes, in fact, adiponectin levels were lower in older dogs. Again, this is a cross-sectional, not a longitudinal study, but we think it goes down as dogs age. And this, too, is associated with a greater risk of frailty, right? So all the components of metabolic dysfunction are falling into place. Too much insulin, low insulin sensitivity, too much adipose, dysfunctional adipose are all driving age-related disease. Same thing with quality of life. Quality of life was poorer in those dogs with lower adiponectin levels. And then again, blood lipids, which, as I say, we don't talk that much about, but here we show a small but significant increase in total cholesterol in dogs as they age. And that, too, is associated with frailty. Now, they're not getting heart attacks and strokes, right? It's not doing the same thing in them that it's doing in us. It may not even be itself a direct driver of age-related disease. It may simply be an indicator of metabolic dysfunction, which is driving disease in other ways. We're not sure yet. So again, going back to this, if you look at total serum cholesterol in their study at Purina, they did not find an association with mortality in dogs, but they didn't find one in humans either. It turns out total cholesterol is actually a pretty lousy predictor of even cardiovascular mortality versus other mortality. We've gotten much more sophisticated in our understanding of dyslipidemia, and so this one is not so important. We know in dogs that triglycerides go up with age, just as they do in humans. And again, they were not able to find, in this particular study, an association between high triglycerides and mortality. We didn't look at that in our study, and I haven't found really much else on triglycerides, so I still think that's kind of an open question. I don't think that the one study, one negative finding totally rules it out. In humans, as you can see, there is a significant relationship between triglyceride and mortality risk. And then a variety of other fats. We looked at total free fatty acids. Remember, one of the aspects of metabolic dysfunction is that you become less efficient at using fatty acids in the liver and in the adipose tissue, so they tend to increase in circulation, and we did associate that with an increased risk of frailty. So dyslipidemia has negative clinical consequences in dogs, even if it's not associated with the same kinds of diseases we think about going along with that in humans. Now, I'm going to get into specific lab values, the CBC, the chemistry, and what we think those mean and what happens when they age. But before we do that, I'm going to step on one of my low soapboxes and talk about normal. What does normal mean when we look at clinical lab values? And obviously, no one should ever say the phrase normal range, right? We've all been told you should say reference interval because normal range implies something is normal. It's a statistical construct. What it means is you take a bunch of animals that you think are healthy, you measure something, you get a nice normal distribution, and you say that the median of that is normal, and there's a 95% confidence interval. So you make this chart, right? And you say, okay, normal is whatever includes 95% of the animals that we think don't have any diseases. That doesn't account for the fact that maybe they have diseases we aren't looking for or don't know about, and it doesn't account for the fact that then 5% of the dogs are outside of that distribution, and that may be normal if they're perfectly healthy. So this raises the question then, if this is the reference interval and it's a statistical construct, how do we know when the change in a clinical lab value is important? So let's say that for some reason you had a really eager owner and you were measuring, ALT in this old Labrador, every month for a year, right? And you saw this pattern. So when are we likely to get excited about this? When do we think that this change matters? We're probably going to say about here, right? The typical guide or rule of thumb is an ALT that's more than twice the upper end of the normal range or reference interval is when we start to get concerned about it, right? But what if I told you that the liver tumor started to grow here, right? Or that the dog started to have metabolic aging and show increased lipid deposition in the liver at this point? There's clearly a trend upward over time. Does it only become meaningful when it exceeds the reference interval? Not necessarily. Right? The clinical significance depends on a bunch of different things. Sure, it does depend on the absolute magnitude of the value. The higher it is, the more likely it is to be meaningful. But it also depends on the context. So if I saw this ALT in a dog and I saw, cherry Kool-Aid in the tube and we had a really hard blood draw, I'd probably be less concerned about it because I know that hemolysis can affect the value, right? Or if I knew the dog had just fallen down the stairs, right, I would think, okay, well, there's probably some leakage. On the other hand, if someone said, yeah, he ate this mushroom yesterday, I might be really concerned about this, even though the magnitude isn't that high, because I know it might be the beginning of something bad, right? Or if there were other clinical symptoms. So we have to put these in context. And part of the reason that I'm giving you this little talk, other than it's just a passion of mine, is that a lot of the changes that I'm talking about, changes in insulin, adiponectin, a lot of things we're going to talk about in the clinical lab values, never leave the normal range. Right? So when I talk about things that change over time that are indicators of unhealthy aging, I'm not just talking about things that go outside the reference interval. And that's where we need to start thinking a little differently about the significance of these values. Trends over time could matter. So let's start with the CBC. This is from a review I did last year on changes in the CBC and the immune system with aging. We talk about immunosenescence, which is a decline in immune function with age, and we talk about inflammaging, which is a cute little coinage that somebody came up with to say chronic low-grade inflammation associated with age. And there are a number of ways in which this manifests. So one of this is looking at total white blood cells. There are changes in total white blood cell counts with age. And you can see here that in general, the trend is for these increases in white blood cell counts to be associated with higher mortality risk. So increased white blood cells probably means there is some stimulation of the immune system, perhaps chronic inflammation. And this is highly significant in all of these different species, and particularly obviously in cats, which is kind of interesting. But higher white blood cell counts do tend to be a marker of unhealthy aging. And another confirmation of that is from that Purina study. Remember, the dogs who lived longer, the calorie-restricted dogs are the ones in the blue there, and then control group are the ones in the red. And one of the things that was different was that those calorie-restricted dogs had lower white blood cell counts. All of this is still within the reference interval. It's a little hard to see, but the gray bar is the reference interval. They all had normal white blood cell counts, but there was a significant, and it turns out meaningful difference in the level. The dogs with the lower counts tended to be healthier and live longer. So that's interesting. Now, the general trend with white blood cell counts is kind of equivocal, but with certain subtypes we see pretty consistent changes. So for example, total lymphocytes tend to go down in dogs as they age, and that's probably a measure of immunosenescence or decline in immune function. However, it's the increase that seems to be associated with the most negative consequences. When you look at particular subtypes, you see some changes which are very consistent with what we see in humans and other species, and which potentially are clinically significant. So for example, the CD4-CD8 ratio changes. That's a very classic measure of the functionality of the immune system. So in people with immunosuppressive diseases, for example, it's often a marker of how well controlled their HIV is, for example. And so we see this change in dogs, which suggests that there may be an increased susceptibility to infectious disease in older dogs. That's one that's still a little bit on the fence. We know for sure that's true in humans. People are much more likely to be susceptible to certain infectious diseases as they age. We're not 100% sure that's true in dogs. Red blood cell counts tend to go down with age, and that is a consistent feature of both dogs and humans, right? And I think we are all kind of used to seeing that, right? Don't we see these kind of low-grade, non-regenerative anemias in a lot of older patients? And if you can't find a particular disease to tack it to, you just call it aging and you move on with your day. But it turns out this may be a symptom of something that's going on. And that applies to hemoglobin, hematocrit, different measures of red blood cell. So in this case, In this study, in all three of these species, but particularly in cats, you can see red blood cell indices were associated pretty strongly with mortality, and higher red blood cell counts were better. So the more severe the decline in hematocrit or hemoglobin with age, the more indication you have that that animal is aging in an unhealthy way, right? And the higher their mortality risk. Platelets are really interesting. So in dogs, this is another one that's different from people. Platelet counts tend to go up with dogs as they get older, and they tend to go down in humans. And that association is actually consistent with the negative health outcomes as well. So in this case, in humans, higher platelet counts are actually associated with greater mortality. They didn't find anything in this study in dogs. But it's an interesting question as to why platelet counts differ. Here's my theory, which I have no evidence for whatsoever. One of the reasons platelet counts decline in people is because platelets get caught up and damaged by atherosclerotic plaques, and they get pulled out of circulation. And platelet counts tend to decline significantly more in men than they do in women, and men tend to have significantly more atherosclerotic disease than women do. So dogs don't, as I said, don't develop atherosclerotic disease, and their platelet counts tend to go up as they get older. That's one of my hypotheses. Nobody's proven that yet. The other thing that probably drives an increase in platelet count is chronic inflammation. Right? And so our concern is maybe that's what this is actually an indicator of in these dogs, but we don't quite know what that means yet. All right, moving on to the chemistry panel. Everybody's favorite, liver enzymes. Mild changes in liver enzymes that are not outside the reference interval. Don't we see this all the time, and don't we wish we knew what the heck it meant or what to do about it? I think it's pretty well established that alkaline phosphatase in particular goes up with age, and in our study, both ALT and ALP phos increased in older dogs. Right? And I think in general, that's another one that we write off as sort of normal aging unless it gets really extreme. But we were actually able to associate both of these with an increased risk of frailty in older dogs. So again, I don't think that these liver enzymes are driving disease or frailty. I think they're indicators of metabolic dysfunction in the liver that tell us that metabolism is moving in an unhealthy direction. So I would say we aren't quite yet at the point where I will tell you to go out and measure these things, and if they're trending up over time, you can tell the owner that dog is at risk. But I think we're getting close to that. And that's what that Purina study was trying to do, is to gather these things together and see if we can come up with a panel that will tell us that, aging is proceeding in an unhealthy direction. And then maybe we can do things. I would say it's perfectly reasonable to see this happening. And if you have a dog who's overweight, talk to them about this might be an indicator that that's catching up with your dog as they get older. Maybe use it as a tool to talk about healthy body condition and nutrition or exercise. Quality of life also was lower in dogs with this non-significant increase in ALT, this reference interval normal increase. And then again, in this Purina study, they didn't quite replicate that. They did find that higher ALTs were actually good in humans. Lower ALTs are more common as people age, as our liver tissue degrades, so we just produce less of it. But they didn't find any significance. So there's a disconnect between the two studies, and we'll need more research to tell us where the true answer is. And then there's just kind of a handful of things. There's obviously alkaline phos, as I talked about. One of the things that I think is interesting is we all care a lot about kidney values because kidney disease is a common cause of mortality in dogs as well as in cats. I mentioned that in the last talk. And it turns out that we didn't really find significant changes in BUN and creatinine in this study associated with mortality. Now again, a lot of the changes that were in this study were changes that didn't exceed the normal range. So if you have really significant changes that mean there's active chronic kidney disease, that probably is a risk factor for mortality. But subtle changes over time, as we see with ALT, for example, didn't seem to be a warning sign in this case. More data to come to tell us that's true. On the other hand, changes in blood proteins were interesting and significant predictors. So globulins go up with age, and that probably represents the accumulation of immune stimulation and reaction over time, right? And albumin tends to go down with age, and both of those tend to be negative predictors. They both tend to predict worse outcomes. Probably in the case of the albumin, it's because there's metabolic dysfunction that's impairing liver function. But there may also be changes in other features like hyperexia, protein intake. We don't quite know what it means, but we do know that it's associated with negative outcomes like mortality. So what does it all mean? What do we do with this in clinic? And the answer is, unfortunately, I don't think we know altogether yet, but I can give you my thoughts and my hypotheses, and then we can talk about what you do with them for now and what you maybe will be able to do with them hopefully in the near future. I've talked about immunosenescence and inflammation, so the changes we see in red blood cell indices, particularly the decrease, is probably a sign of increased chronic inflammation and decreased red blood cell production may have to do with some protein metabolism as well. The increase or decrease in white blood cell counts varies, so they tend to go down with age, but when they go up, that's usually a bad sign, right? And the increase in platelet count, I don't know if we know yet if that's clinically significant, but I think it's a sign of chronic inflammation. Changes in chemistry, I've already talked about how albumin and globulin are really important indicators of both liver function and immune system activity. And I think those are good early warning indicators that something is up. And then changes in various chemistry values are almost certainly reflections of metabolic dysfunction. Increasing insulin, decreasing adiponectin, changes in blood lipids, and probably changes in common liver values are all indicators of unhealthy metabolism. Something is going on that is likely to increase the risk of frailty and declining quality of life. The study that Purina did with this, as I said, took a bunch of common lab values and put together an age, a biological age measure. And then they compared that to chronological age to create what they call age dev, or the difference between your chronological and your biological age. And I mentioned in the last section that this is what we're working towards being able to do. So then in this study, they retroactively applied that to the dogs in the caloric restriction cohort, where they already know the outcome. And they found some really interesting things. One is that starting at about 7.5 years of age, the dogs in the calorie restricted group had a lower biological age relative to their chronological age than the dogs in the control group. So this tool, this age marker, was a pretty good predictor of where they were headed, right? The average life expectancy was, 12 to 13, 14. So, this is 6 years earlier. They were able to see this difference in biological and chronological age and predict mortality outcomes later, right? And we know that the main driver of longer lifespan and longer health span in these dogs was probably better metabolic health, right? And so I think this might be a sign that this kind of tool is coming and useful. Now, we're going to want to apply this to other cohorts. These are just Labrador Retrievers. Does this work the same way in Yorkshire Terriers? I don't think we know. How does this work in owned dogs who are fed a variety of different things in a kind of normal environment? I don't think we know. So there's still work to be done to develop tools like this. But I think it's not going to be that long before you see things like this in practice. Someone asked in the last session, what about all the ones that are already online, right? You can already go on and get a biological age measurement by putting in some lab values and other things. I think we're not quite at the point yet where that's effective in guiding clinical therapy, but I think we're going to get there. And this is one of the more interesting and exciting bits of data to support that. Now, we've talked a lot about mortality prediction, and that's what these tools are usually tested against, because death is a pretty clear, discrete outcome, right? And we aren't, there's nothing fuzzy about it. But it's not that useful to me as a clinician. I don't want to go to my client and say, well, I ran this little tool, and your dog is way more likely to die in the next 2 years than somebody else's dog. Who wants to hear that, right? How does that help me? What I want to use this to do is to predict other outcomes that I can actually do something about. So, for example, frailty risk. In humans, frailty is not only something that predicts outcomes, it's something that can be changed. So if a person has a high frailty score, you can work with them to increase exercise, to change their diet, to improve their social contact with other people, to treat their diseases more effectively. And you can watch that frailty number improve and get better outcomes. So if we could prove that these kinds of measures are predictors of frailty or quality of life and change them for the better, that would be clinically useful. Another thing I like is what I call risk stratification. The example I usually give is, you have two dogs the same age, maybe they're 14-year-old, Boston Terriers, and they come in and they've got just terrible, terrible dental disease and they need a whole bunch of teeth out. And the owner is like, I don't know if I want to do anesthesia or dentistry on this dog. He's old, right? Well, some of those dogs are going to do great, live a long time, and benefit from that important therapy. Some of those dogs may be high-risk anesthetic candidates or may pass away from something else in 6 months, and then you'll wonder if it was worth it, right? This is a tool that you could potentially use to decide. If you could use frailty or you could use a biological age measure to tell you which ones are robust and healthy and had a good chance of getting through the procedure and living a while, that might help you and the owner to make decisions about when to do, stressful medical interventions, for example. I don't think we're there yet. We haven't proven that they're good for that, but it's a lot more useful than predicting mortality, and it supports decision making. So what do we do in the meantime? Well, people like me, we collect more data, right? I mean, obviously we need more data. I don't want to wait until the story is complete to tell you, but I know that leaves you a little frustrated because there's stuff we don't know yet and we can't do. In the meantime, I think it's useful to follow these trends. The American Animal Hospital Association guidelines for senior care recommend doing routine CBC chemistry and urinalysis every 6 to 12 months on senior dogs. I think that's a reasonable recommendation. I tend to like to do that every 6 months if they're healthy as far as I can tell. If they have specific diseases I'm managing, I'll often do it every 3 if they'll let me, or at least some of that. And follow those trends over time. Because if I see a curve like that ALT curve, I mean, I'm going to pay a little attention to it before it gets outside the reference interval, particularly if it fits with this story, if there are other indicators of metabolic dysfunction, for example. And consider using some of the other tools out there to see if you can pick up things early. Use a frailty instrument or use a quality of life tool routinely and repeatedly in your dogs as they get older, and see if you notice trends in time, because that may give you something useful to point to the owner to help encourage a better lifestyle or other things. I encourage people to take a preventive medicine approach. Get ahead of these things as much as you can, right? So we already talked about the most important thing you can do is help your clients to get their dogs to a healthy body condition. That's really important. We probably don't talk enough about activity and engagement. Keep them mentally stimulated, keep them physically active, and then obviously make sure they're coming in, getting monitored, getting their diseases treated. All of these things are things that are well established in humans to improve outcomes. They probably do in dogs as well, even when we don't have a lot of data to show that. How do you improve metabolic health? Less fat, more muscle. Muscle is a really metabolically important tissue, and fat, especially abdominal or visceral fat, is pretty negative in terms of health. How do you get there? Well, traditionally, less food, more activity, right? You do more exercise and you eat less. Is that an easy, simple panacea to all of our metabolic health problems? No, it's not, right? I think we need to find better and more effective ways of encouraging healthy lifestyle habits in our patients. But I think we need to look for other opportunities, and that's where companies like Loyal and others that are out there working on medications to try to address some of these problems come in. We're working on a medication called LOI2, which is specifically aimed at targeting some of the metabolic dysfunction that occurs with age. It's going to be a FDA approved prescription drug ideally, so we're trying to go through the process as rigorously and scientifically as we can. And the goal is not to replace healthy diet or exercise. The goal is to provide another tool to try to improve health and outcomes. So there are lots of other things that you could do besides that. We're talking about insulin. There are drugs that sensitize to insulin and improve insulin levels and sensitivity. There are drugs that improve adipose tissue, that reduce adipose amounts, that improve the distribution or the function of adipose tissue. There are drugs that obviously lower blood lipids and improve your lipid profile, right? And I think there are lots and lots of people in academia and industry studying a lot of these different drugs in order to find additional tools to help deal with mechanisms of aging, and in this case with metabolic dysfunction. So I think it's not going to be very long before these kind of things start to appear, and part of my job here is just to sort of give you an idea of why they exist, how they might work, what we're trying to accomplish with them. Okay? With that, I will say if you want to scan the QR code, there's a little survey about the session and also about what are the things you want to hear about, because I'm always building new talks. And then if you do that, I believe we have, yes, Kevin over there has some cute little tote bags you can pick up if you fill out the survey. In the meantime, I'm happy to take questions. Yes. Yeah, it's so frustrating. One of the big things that I hear from clients when I say feed your dog less is, then my dog is hungry and they're pestering me and they're ripping open the cabinets and they're doing bad things, right? I'm just going to do a little drum solo there for you. So one of the problems with that is people actually don't like it when their dogs have a lower appetite a lot of the time, right? We're talking about Slentrol, right? This is a weight loss drug for dogs a long ways back, and nobody used it because the dogs didn't want to eat and that made them feel bad, right? So drugs that reduce appetite and reduce weight are going to be tricky in veterinary medicine because people don't like that. On the other side, as you say, sometimes it would be nice if they were less food driven, and that seems to be a breed and a personality thing. I mean, I don't think there are pharmacological answers to that are tenable or that are effective or proven. I tend to shove a whole lot of fiber in dogs like that, so I feed them a big pile of green beans on top of their food. I have a dog that's half golden, half Malinois, and so you can imagine what mealtime is like with her. So she has food puzzles and food balls that take her time to eat, so they slow her down and give her more to do, and then she's less likely to just inhale a cup and a half of food and look at me like, where's the rest? So, I mean, those are the kind of strategies we've used for a long time, and that's still what I think we have. Other questions? Okay, well, thank you guys for coming. If anybody's shy, I'll hang out up here. You can ask me questions. Thank you.